Keeping the money on the table, going through the annual budget and appropriations process alone is no small notion. The money that is there available for the NIH to provide these research grants that now finally are coming to our community, the resources that are available through the CDC to provide the grants that fund many of our community-based organizations, and finally the resources that go through Ryan White that provide a lot of the drugs and services. That's an annual process that must happen. It is critically important, and this year it's more important than ever. In part because the Patients Protections Affordable Care Act, this ingenious model of care that the Obama administration decided it was going to have as its primary objective for the first 2 years of the administration, is at risk. It's an important piece of legislation to black gay men because for the first time, it provides medical care and support for people who are uninsured at 133% of poverty. And you saw those poverty numbers up there. Those are our people. And so finally for them to have access to health care across the board was an incredible opportunity. And many of us understood that while it wasn't HIV specific, to have that kind of access available to our entire population, the details of the regulations and implementation would happen inside HHS and at the state level. But that initial macro concept of insurance for all and access for all was critically important. And that is at risk at the moment, and we have to do everything that we can to avoid that being scuttled. Some of the things like pre-existing condition protections, extending the coverage to for people who are 26 years and below to their parents' health insurance, elimination of the internal spending caps, elimination of disenrollment for insured folks when they become ill, federal assistance for the premiums, deductibles, and the co-pays, and the expanded support for community health centers where a lot of our folks get their care. All of those things are part of this, this important piece of legislation. And finally, how Ryan White, which is a discretionary program that we have to fight for the appropriations every year, how will that program wrap around the Affordable Care Act when we set up what's going to be called the Essential Benefits Package, what everyone will get when they're insured? Some things are going to be left out. Some of the things that people currently receive, for example, are going to be left out. How do we ensure that they're still able to access those services through some other funding source like Ryan White, even though they're insured nationally? That's what we do. That's what the MBGMAC is doing. That's what I'm doing. That's what other policy professionals are doing at the moment. And in fact, it dovetails very nicely with another brilliant proposal from the Obama administration, the National HIV/AIDS Strategy. For the first time in this country, all of the resources that go to HIV have been documented and identified and cataloged across all of the departments. And the key departments, Health and Human Services, HUD, Department of Justice, Social Security Administration, and Labor, all have put their resources on the table so that we can see where they are, so that consolidation and effective collaborations can occur. Never before done in the history of the epidemic. Critically important. We spend almost $19 billion domestically on AIDS. It doesn't feel that way. It doesn't feel like we spend that kind of money on the problem. And so finally, to get a handle on it, it's going to be very important for black gay men who are identified and targeted in this plan as the key driver, one of the key drivers of the epidemic. Gay men, period, but black gay men within gay men are identified as the key target population that must be addressed. And all of this must happen, says the president, in an environment where we expect to have flat funding. So what does that mean? That means that the resources that are currently on the table have to be redirected. That means that all of the haves, as Dr. Chaptal said, that currently are doing things that don't target these populations may in fact either have to change their business, which is probably what they will do, and that might be to our good, or they'll lose their funding. And it will only happen if we stay diligent. All of us have to understand that that's a mandate from the president, and we have to treat it as such, a mandate, something that must occur. And I think that the biggest challenge that we have to that, and is the thing that I'm going to end on, is when I look across the country at the organizations that say they're by and for the black gay community, there's like 8 of them. Which takes me back to my original question earlier in the day. 8 organizations don't have the capacity to do what needs to be done in this epidemic to stem the tide of infection in the black gay community. And so all of this conversation about if you're not indigenous, you're not authentic, if you're not indigenous, then you can't do the work, you're not for us, that has to go away. We don't have time for it. It doesn't make any sense. It's not logical. And so, quite frankly, that's a very big, critical piece for the research community. Can the research community identify community-based structural interventions that result in the creation of organizations in high-risk, low service capacity parts of our country that actually provide the next step to service delivery? Can we incentivize some of you who can take some time to grow and nurture those organizations? Because that's the other challenge. Many of our service organizations aren't necessarily the right fit at the top. The people who are running them aren't necessarily people who are skilled with the actual service delivery that needs to be provided in the future. The biomedical, HIV prevention and care model that's being pushed all across the country takes a very specific set of skills that don't necessarily match people who came to the epidemic early, let's say, out of a sense of need and priority because their community was at risk and they just knew they had to do something. That's very laudable, and people should be commended, get a plaque. Let's have a dinner. But you don't get to run the organization for the rest of your life when we have a whole set of new needs in the community. It's a community-based organization. It's not you. And so we've really got to shift that along. And I think, I say it only because I say it with love. I do, because it really is something that must be done. And there are too many instances where the organization falls apart. We find out after it is closed that the reason it's closed is poor administration, mismanagement of funds, a grant that was sustaining the organization didn't go in on time, and so now the organization has to close, everybody has to be laid off because of some silly mistakes that should have never occurred. And they're the only organization of their type in a community. That kind of stuff has to go away. And so I say that that's one of the huge challenges that we have within our community. Let me see if there are any other ones that I want to actually highlight. I think that once that happens, once we have the right service mix and we have the right people providing those services, we'll be well on our way. Because I think we have a very responsive administration. We have very important key people in place. I mean, to have Greg Millett doing the things that he's doing, to have Kevin Fenton in a position to do the things that he could be doing and needs to do more of and will do more of with our support, to have people at the NIH doing the things that they're doing. This is our time. But the things that seem to me to be critically missing are after we get people to agree at the highest levels of government and they're ready to write the check, where are they taking it? Where is it going? We have experienced this. You've made your case. I agree. It's time to do something. Where should it go? And then I look out on the diaspora of, some really serious problems, and then we have to ask ourselves, our credibility is at risk. I can't just tell you to plop it someplace knowing what I know. And that's a serious challenge that we have. So I hope that's at least an opportunity to start some dialogue here in the room so we can start to have that conversation, because that's one of the conversations that I actually think has been burbling on the edge, and we really haven't gone there yet. I'm hoping that we can. Thanks.
Actually, this is a nice segue. Could we actually have the panelists come up, because we're going to be talking about next steps. Where do we go? Right. So.